thank Dr. Vijay Banga and office bearer of CSI for giving me opportunity. So this is what meant out in today's session. This is about the beta blockers in a PAMI era. We know that the beta blockers now we are giving in all MI patients, but of course when we see the data wise, so we know that the ischemic heart disease and the role of the beta blocker was first line treatment when the reperfusion era was not there. There was a strong evidence that it has got a mortality benefit. But after the reperfusion era, thrombolytic era and the primary PCI, where the beta blocker stands, of course, we know there are compelling indications where the beta blocker is much like heart failure and all. So this is a time-bound treatment for the management of acute MI. We know that the antiplatelet and reperfusion strategy either in form of primary angioplasty or thrombolytic therapy, and of course the beta blockers, AC inhibitor or ARB, and of course the MRAs and all these things comes in a role. And we know that the role of the AC inhibitors and as well as the beta blockers, and beta blockers has got a certain indications like of course the arrhythmia or the tachycardia, atrial fibrillation, hypertension, also common risk factors, and LV dysfunction, and all these things where beta blocker is a must. So gloomy picture is where the patient has a low risk group of patient and patient having a normal ejection fraction, and they were reperfused timely manner either in form of thrombolysis or primary angioplasty. So where we stand, that data what we need. So what about the clinical trials say that when we see the older data, pre-reperfusion era, we have got all these studies, BART group, Gothenburg metoprolol trial, Miami study, and ISIN-1. That was done with the propranolol and of course the atenolol and timolol and all this. At that time the study was done, and of course it has shown the beta blocker has shown the mortality benefit when it was given. And then the thrombolytic era started, and some of the studies came at that time also, like PAMI 2B study, Gusto-1, post-hoc, Commit, and Capricorn. We note that the Capricorn trial was done with carvedilol with LV dysfunction, and that study has shown benefit with carvedilol with LV dysfunction. Of course, the PAMI 2B study and Gusto-1 study, and that was at that era after thrombolysis, we were routinely giving the IV metoprolol, and that has shown the reducing the reinfarction rate and as well as the ischemia, and of course some of the arrhythmia benefit, but mortality benefit was not that much there. And of course, Gusto-1 has used the atenolol, and it has reduced it has got some mortality benefit and all. And the Commit was one of the biggest studies, the Chinese study, and that around 45,000 patients has been studied. And that study has given some of the beta blockers should be widely chosen, and of course there was not much mortality reduction. Some mortality reduction was there by arrhythmia reduction, and that was lost by cardiogenic shock and heart failure deaths and all. So that has created a question toward the routine use of IV beta blockers. And of course, then some of the data with the PCI era that I'm going to discuss in detail in my later part of my talk. So this is in the thrombolytic era. Already I have discussed some of the studies. They have gone some of the benefit with the LV function and all. But when we see the meta-analysis by the Bangalore et al. And Sripal Bangalore et al. Has shown that there is no mortality benefit, and there was some benefit in reducing the reinfarction as well as the angina episode. But some benefit we have lost by heart failure and cardiogenic shock and all. So that was with the thrombolysis. And what about the PCI era? And these are the study has been published. Cadillac trial, that was with F6 there was the beta blocker. Early use of IV beta blocker, where the patient was not on the beta blocker. If they were given the beta blockers, that group of patients, they have benefited. So before the PCI, if they were not on the beta blocker, if we give beta blocker in a correct, in a patient, those who can tolerate, like class 1 or 2, 3 or 4, we have to be very careful. That is a trial, all this trial has shown the same thing. Metocard's scenic trial also, the same thing, and it reduced some of the heart failure episode and some of the benefits. So early users of the beta blocker, in these two study, beta blocker were some of the positive results, arrhythmic death were reduced and all these things. But this early PAMI trial and another early PAMI trial has shown that important the early pre-perfusion admission of IV metoprolol at a dose had no beneficial effect on infarct size in patient with STEMI treated by primary PCI. So these two trials are a little bit controversial. And then the BEAT AMI trial and some of the other trials have shown that the infarct site and enzyme elevation, and they have shown not much beneficially with this beta blocker studies. So here also some of the gloomy picture was there. And then one study has been, and then the meta-analysis has been published. So when they studied the meta-analysis, and they have shown, this meta-analysis has shown that patient undergo primary PCI, the use of early IV beta blocker is safe, but it reduces Another important thing is that main outcome, mortality benefit is not that, but some of the reinfarction and ischemia benefit is there. And some of the small observational meta-analysis also shows they say some of the benefit, mortality benefit with beta blocker. So observational data, some positive result in meta-analysis. And then the study of J-minute registry, that is 2022 published. And that is something that they have studied around 1,500 patients. Here the beta blocker, Japan, they are using the more or like bisoprolol and the carvedilol. And this was a study done with a ejection fraction more than 40%. So this was relatively normal ejection fraction group of patients they have studied. And this study was positive study, and it has shown that composite cardiac endpoint were lower. And this was with a newer beta blocker. But here also, some people argue that here the beta blocker was not randomized study. They have given the beta blocker particularly like entry-level MI, so or patient with hypertension, dyslipidemia. So somewhat little bit higher risk factor group of patients, they have given the beta blockers. But here they have given the beta blocker was a newer beta blocker. So of course, we require study with a newer beta blocker like bisoprolol, which is lipid neutral, glucose neutral, vasodilatory property. So newer beta blockers can become a choice in case of somewhat high risk group of patients with normal ejection fraction post-MI patients. So some of the newer studies, like the guidelines I'm going to tell, but these are the studies, whether in all the patients, of course we know that the LV dysfunction group of patients, we have to give the beta blocker lifelong, but the patient having a normal ejection fraction, now the current guidelines, they mention up to 3 years. But here the newer data will come that after 6 months, whether we can stop the beta blocker or not. So ABYC's reboot trial and sweetheart trial, where the metoprolol and bisoprolol will also going to be studied. So these are the studies going to be published in between 2023 to 2025. And recommendation, of course, all of us, we know that we should give the beta blocker if the patient having a low cardiac output status, cardiogenic shock, where we have to be careful. Otherwise, we have to give the beta blocker, we have to use the beta blocker wisely. Another, and of course, the LV dysfunction, we have to give them. And another important thing, there are some of the articles, like Sripal Bangalore also, he has mentioned also that in current era, where the rapid invasive procedures are there, latest generation of drug-eluting stent, we have got a statins, antiplatelet drugs and all. So whether multivessel we are treating, almost we are doing the complete revascularization. In that group of patients, whether the beta blockers are beneficial or not, that needs to be decided. And these are some of the meta-analysis also say that we require further trials. Those patients who have got a normal ejection fraction, low risk group of patients, whether the beta blocker should be given 6 months or more than that, up to 3 years. So that we require some of the newer data. So to conclude my talk, in the treatment of patient with myocardial infarction, beta blocker reduce the mortality in the reperfusion, but not in pre-perfusion era, but after the reperfusion era, there was a short-term reduction in myocardial infarction and angina. And of course, the beta blocker, even the J-minute registry has also told that by giving the routine beta blocker, it can increase the BNP level and of course the heart failure admission. So routine use of beta blocker should be given or not. And of course the arrhythmic death will be reduced. And initial trial like Cadillac and Metocard were positive, while the later trials were almost neutral or negative in all patients. And of course the newer beta blocker might make a difference, that the future studies like ABYSS, reduced seed heart and reboot CNIC will tell further. So that will decide the future of beta blocker in low risk group of patients with normal ejection fraction post-MI, whether we should continue beta blocker long after 6 months up to 3 years or whether lifelong. Thank you so much.